joining us. We're going to get started in just a few moments. Welcome, everyone. Those of you who are just joining us, we're going to get started in just a few moments. Welcome, everyone. We'll get started in just a moment. Thank you for being with us today. Well, welcome all. I'm Michael Morella, Managing Editor at US News and World Report. Today, we're exploring how hospitals are combating food insecurity and addressing hunger. Today's webinar is part of our ongoing Healthcare of Tomorrow series, exploring some of the most urgent issues facing the health industry, along with the cutting-edge solutions that are emerging to address them. I encourage you to visit usnews.com/healthcareoftomorrow to learn more about some of our upcoming programs and for a wealth of other content. Now, before we get started, just a couple of quick notes. We are recording video of today's session, and we'll be making that available once we conclude. Look for a follow-up email from our team. And later on in the hour, we may have some time for your questions. So those of you in the audience, as you have questions, we ask that you please type them into the Q&A feature in Zoom on your screen. Our team will review those and our moderator will give voice to them as we can. Now I am honored to welcome our panel. With us today are Dr. Lisa Harris, Chief Executive Officer of Eskenazi Health, Mikkel Moore, Senior Vice President and Chief Community Health Officer for Intermountain Healthcare, Pamela Schwartz, Executive Director for Community Health at Kaiser Permanente, and Dr. Kara Odom Walker, Executive Vice President and Chief Population Officer at Nemours Children's Health System. Thank you all for being with us. Leading the conversation is Liz Whitehead, Managing Editor of Events at US News and World Report. Liz.
Thank you, Michael. According to the USDA, some 38 million Americans, including 12 million children, did not have enough food to meet their needs in 2020. The health implications for families are profound and have only become more critical with the added stresses of the pandemic. We are fortunate to have leaders on the panel today who can share how healthcare systems nationwide are moving aggressively to take on these challenges. Kara, if I can start with you. As a major children's health system, Nemours has zeroed in on food insecurity as a major priority. Can you sketch out the communities you serve and why you believe that focusing more intentionally on eliminating hunger and improving access to more nutritional food will improve population health and lower health costs by fending off chronic diseases?
Thank you, Liz, and thank you for elevating this important issue. Nemours Children's Health provides direct care in 4 states, including our 2 freestanding children's hospitals, but we have 23 community hospital partners and more than 75 primary, specialty and urgent care locations. We're investing in building population health and our advocacy initiatives to really highlight these issues and reach children who will never walk through our doors. But we also know that providing care and the whole child health model that we embrace includes nutrition. It includes nutrition and food access as an essential part of health. And healthy eating in childhood and adolescence is important for not only education outcomes and health outcomes, but we also know that it extends into the long and hopefully thriving lives that all children deserve. So this is what we mean when we're saying we want to go well beyond medicine. We recognize these outcomes are not just limited to traditional healthcare, but eating a healthy breakfast is associated with improved cognitive function, reduced absenteeism in schools, and improved mood. And all of these sectors need to come together in the places that kids live, learn, play. We're caring for the same kids and want to make sure that we're looking not only at improved health, but also improved cost and experiences. And I look forward to sharing more about the work that we're doing.
Lisa, can you pick up on some of Kara's comments? Eskenazi is a critical safety net hospital in Indiana. Can you explain why in that role, it is so critical for you to focus on population health and food insecurity, and which is really care outside of hospital walls in many cases, in the home and elsewhere?
Well, thank you. And again, my thanks also for convening this group. We all care deeply about this, and we're glad that you're shining a light on it. And I think it was great that we started with children too, because I think that's where the biggest opportunity is. And so, you know, as you said, for those who don't know what a safety net health system is, that means that our mandate and our mission that we embrace is to care for all within our community, regardless of ability to pay. And that puts us squarely in the middle of caring for our community's most vulnerable residents, those who, due to long-standing and systemic inequities manifest as what we now call the social drivers of health, bear the largest burden of chronic disease. Medicaid is our primary payer, and fewer than 10% of our patients are commercially insured. And so we long ago, as you alluded, realized that all the care we provide in our state-of-the-art hospital and through more than 1 million visits to our primary care centers and mental health centers throughout Indianapolis, notwithstanding, we know, as Kara said, health doesn't happen within the walls of our hospital or our clinics. It happens or it doesn't in our neighborhoods. And we know the strongest predictor, it's an unfortunate truth, that the strongest predictor of health and longevity is zip code. And it's the short end of the stick zip codes that we focus on when we decide where we're going to put our next neighborhood health center. And from those health centers, we deploy community health workers and community weavers, reaching out to individuals and community partners. Because over decades of caring for large numbers of low-income individuals bearing a disproportionate burden of chronic disease, we've learned that our resources go farther, the farther upstream we go. And research has borne out that 80% of chronic disease can be prevented, better managed, and in some cases even reversed by focusing on nutrition and physical activity. And this requires, though, that access, for example, to healthful food and stable, safe environments be available to all, not just the fortunate few. And we're obviously looking forward to talking more about that as we progress.
Pam, Kaiser Permanente has a multi-state reach, and that can present its own challenges of identifying and tailoring food insecurity strategies for different regions. Can you talk about that, and also how your emphasis on value-based care makes focusing on this issue so important?
Yes, and thank you for having me. As others have said, it's such an honor to be here with such distinguished leaders from health systems who are really making bold investments and systemic changes to address the social determinants of health, but specifically food here. So a bit about Kaiser Permanente. We're the nation's largest nonprofit integrated health system, so both a health plan and health providers working together to improve the health of our members and our communities. And we've been around since World War II, and we serve more than 12.6 million members across 8 states and Washington, D.C. And like others have said, so there's going to be a lot of ditto in what I say, we believe that being healthy is not just the result of high quality medical care, but things like safe housing, balanced meals, transportation, social connections. These are all foundational to health and well-being. So I'll say a little bit about how we entered into the food insecurity space. And I'll also say that in 2020, we surveyed over 10,000 of our members, and we learned that our members were struggling with their social health. 2/3 of our members had at least one social risk factor, and those members were more than 7 times more likely to report fair or poor mental health. And nearly half of our members were experiencing financial strain, over 1/3 social isolation, and nearly 1/3 reported food insecurity. And they also wanted us to ask them about it. 1/3 of our members said they would welcome assistance from us. And so we've been building a robust portfolio to address our members' social needs, starting with food insecurity back in 2018. So I'll add that we have like others on the call, we have a long history of addressing obesity prevention. We've done a lot of work with Nemours on that, and also nutrition and food insecurity. And we believe, like others have said, that everyone in the nation has the right to the most basic of human needs, including nutritious food, and that nobody can reach or maintain their best health without those needs being met. And in 2018, this is how we got started with really rolling up our sleeves here. In 2018, our CEO at the time posed the question to our entire workforce. He asked over 200,000 employees, how can we best ensure that basic human needs are met to create healthier years? And not surprisingly, from what you've just heard from others, over 50%, this is over 2,000 crowdsourced ideas, highlighted that health is more than just healthcare. And what rose to the top was the most basic of human needs, and that was food. And so from there, we embarked on a rigorous human-centered design process to really identify the specific initiatives where we can make an impact on our members who are experiencing food insecurity. And we started with gathering insight from a variety of sources, leaders in the field, to really understand the issue and the role of healthcare and being part of the solution. We talked to individuals with lived experience, really trying to understand the barriers and co-create the solutions. We looked at the evidence, and then we looked at the great work that was already underway to see what we could accelerate or scale. And over the past few years, we've been building a comprehensive national approach to really transforming the economic, social, and policy environments that are related to food, so that people across the nation can have access to healthy, affordable food.
Thank you, Pam. Mikkel, Intermountain plays a very important role in Utah and sort of identifying what are the most important issues and getting partners together to attack them. I'm interested in 2018, you worked with 2 Utah cities on a pilot at, looking at food and housing security. Can you talk about that and how that influenced your current overall strategy to address these issues moving forward?
Yes, Liz, thank you. Intermountain Healthcare, I think, was, like many health systems, recognizing the role of the social drivers of health, but also wondering, what is the role of a health system to address those? And how do you meaningfully change our processes so that we're incorporating screening for social needs and then connecting people to resources as part of the workflow? And we wanted to design solutions that would be applicable throughout our service area, which is growing. We now serve an 8-state region across the Intermountain West in both urban and rural environments. So we were really intentional in saying, let's create a demonstration project, a demonstration for ourselves, but also that could be a learning environment for the nation and how to do this. And we're intentional. The communities we chose are really different, one urban, one rural, different politically, different actually in their demographics, how long they've been organized as a community, and even what community partners existed to work with. And our objective was to partner across lots of sectors to identify people at high risk for social needs, with the theory that if we mapped and addressed those social needs, that we could reduce medical spend and improve quality of life. And so those partnerships are really robust now in both Weber and Washington counties. One, we joined an existing coalition and brought additional resource and capability to it. In another case, we really convened a community coalition for the first time. And in the course of that, we uncovered some of the barriers that were in the way of trying to meet people's needs, including resolve food insecurity. So really began to understand the makeup of small food pantries relative to large food networks, and problem solve some of the infrastructure that exists in supporting that community, but also began to understand issues of insurance coverage, housing, transportation, and other issues that really are around that. What it's led us to do then as a system is change our processes. We now screen all of our patients for social needs and are able to connect patients and members to food, but also to other solutions, housing, utility assistance, and other mechanisms. We've also designed from that predictive analytics to help us predict who needs to be outreached, because we're not always encountering the people who are in the most need. And I'd be happy to talk with you about that further. So we've used the demonstration to help us redesign our systems, but also the way we work with community partners.
That's great. I'd like to now try to drill down into some of these programs. Kara, I'm going to ask you to do a little more setup again. Can you talk a little bit about the food as medicine movement, and what does it entail? And how do you see the allocation of support for the programs like Food as Medicine in terms of a very good use of healthcare dollars in treating people and their chronic conditions?
Food as Medicine does sit at the crossroads of nutrition and healthcare. In the most basic sense, as a family doc, I would be able to write a prescription for my patient that's sitting in front of me and have it covered. And that coverage and that pathway would be just as basic as prescribing a nebulizer or a prescription. We have a ways to go in most places in our nation to make it that simple, but it can take multiple forms. So as a recovering policymaker, where I was running a Medicaid agency, I wanted to have food and medically tailored meals as part of our coverage in Medicaid. I wanted SNAP benefits to be connected to those who would most benefit from healthy, nutritious options. It took a lot of doing because our social programs don't necessarily connect in the most simplistic ways that we think things should work for those who would most benefit. I mean, if every patient with diabetes who also was eligible for SNAP could also have a robust benefit around fresh fruits and vegetables, we probably would prescribe a lot less medications. We're not quite there, but it can take the form of medically tailored meals, medically tailored grocery delivery, or produce prescription programs where people do get an enhanced benefit for those types of healthy options. We also know that the chronic diseases mentioned earlier in our setup are leading to an epidemic of ongoing challenges with managing both costs, but long-term outcomes. And in fact, 1 in every 5 deaths across the globe is attributable to suboptimal diet, more than any other risk factor, including tobacco. I mean, that is just impressive, yet we don't necessarily have a healthcare system that has optimized what the benefits of nutrition could be. And that's why I think finding creative ways to create these financial incentives, behavioral interventions can be important to support healthy eating and nutrition. It's really important early in life for the work that we do as a children's health system, but it's even more important for adult systems. So trying to figure out where we can connect not only our clinical interventions, our social screening tools that we're also doing, but also how we work with policymakers around nutrition policy and SNAP benefits and WIC and home delivered meals can have a long-standing impact. And so I hope that our lessons and our leading edge of this work as health systems that are working in this space can lead to a space where we do have just as much impact as pharmaceutical coverage. We can treat an entire family, not just the patient in front of us, through efforts around food as medicine.
Yeah, I'd like to drill down on this a little bit more with Lisa. How does Eskenazi integrate food as medicine into patient care, particularly for discharged patients? And how do you adapt instructions to be compatible with people's situations? I mean, some people have ovens, some have microwaves, some refrigerators. I mean, it has small refrigerators versus big ones. How do you adapt to all that? And what have you seen? Have you been able to do any studies on the impact on readmission rates for certain chronic conditions?
Well, thank you, Liz. Actually, I could pivot 2 ways from what Kara had to say, but I'm happy to start here. And I want to go back to the food as medicine prescriptions too, though. But I think we've made reference to food as medicine. I think it might be helpful to give some examples first to say how powerful food is as medicine. It's really more powerful than pretty much anything we have in our pharmacologic armamentarium. The Mediterranean diet combined with 150 minutes of weekly exercises reduces the risk of type 2 diabetes by 60%. And it also reduces the risk of cardiovascular disease by 25 to 70%, depending on the particular demographic group and the endpoint you're studying. So this is not around the edges stuff. This is really where the opportunity is. And we've also long known about the importance of a low sodium diet in managing congestive heart failure. For an individual with heart failure, a holiday meal can land them in the hospital. And in the controlled inpatient setting where we can restrict sodium intake as an essential part of treatment, they usually tune up pretty quickly. The problem then is when they return home. So in 2015, we launched a program through which individuals with heart failure were given the opportunity at the time of hospital discharge of 30 days of free low sodium meals that we prepared in our hospital kitchen and partnered with our local Meals on Wheels to distribute. So that gets to the medically tailored meals that Kara was talking about. And so we combined this with other services, including continued education on the importance of reducing sodium intake to prevent, further trips to the hospital, and also social services referrals as needs were identified by the Meals on Wheels delivery team. Patients receive this kind of information while in the hospital, but that may not be, it's usually at the time of discharge, it may not be the best time for them to be capable of effectively absorbing the information. It's much better to have the opportunity of having a discussion in the context of the patient's home environment, especially in their kitchen, tailoring it to the education, their dietary preferences and their resources, as you say, whether they have an oven or if all they've got is a microwave. That would change our discussion. So guess what, with this intervention, readmissions to the hospital for heart failure decreased by 50% for the group receiving this intervention. And so I think this is also where food as medicine, in addition to improving patient outcomes, becomes good business as hospitals receive financial penalties for readmissions. So that this initial pilot formed the basis for our medically tailored meal program that expanded first with funding from the Ryan White program to provide about 35,000 nutritious meals each month to Indiana residents living with HIV or AIDS. And then we've continued to expand from there, partnering with a host of community organizations to the point that we're currently providing another 7,500 medically tailored meals on a monthly basis, for example, to homebound seniors, to adult day centers, to chronically ill, food insecure individuals, cancer patients. So yeah, that's a story that emanated from the inpatient service.
Pam, pick up on any of the points of the previous panelists, and I want to add to that. During the pandemic, many heads of household spouses lost their jobs and they had no savings to fall back on. They may have lost their ability to travel anywhere to go get food. There are Meals on Wheels programs, et cetera, that are doing delivery, but what was the impact on access to food, availability of food to people the last 2 years? And did it change the way you try to reach people in the community?
Yeah, thanks. And yes, we're all doing similar food as medicine interventions, so that's super exciting to hear and learn about. Well, we all saw how COVID-19 exacerbated food insecurity, and when COVID-19 hit, I was inspired by how health systems across the nation, and I had a front row seat to my own, which is large, how we were able to quickly meet the emerging needs of our members. So I'm just going to mention a few examples, and I'm going to pick up on SNAP actually, because there was a lot that happened in the SNAP environment during the past 2 years. And we started SNAP outreach back in 2019. So this was just before COVID. And at that time, we launched an innovative, inexpensive texting approach to really outreach to low-income members to help them apply for SNAP or food stamps. And we combined this with phone support for households who needed extra help. And when COVID hit, we accelerated our SNAP outreach, and we had started in California, and we now scaled it across all of our footprints. So a reminder that that's 8 states and Washington, D.C. We also went back to the first campaign to pick up on those who are newly eligible due to the loss of a job. And then also as the dollars for SNAP increased, which they did some months in, we were able to really go back to our members and really make sure that we could quickly message to let the members know about the increase. And to date, we've reached over 4 million members and assisted 95,000 members to apply for SNAP. And we also estimate that this kind of a simple texting campaign has put more than $34 million into our members' pockets and nearly 50 million into the local economies. So that's something to mention. And also our work with SNAP demonstrated to us that there's a role for healthcare and connecting our members to government programs like SNAP. And we hadn't done that before. And we've been building new initiatives with this in mind. And I'll just briefly touch on 2 additional things. We also worked quickly to launch two temporary programs to support members during the pandemic. the first was for our members who tested positive with COVID and who also screened positive for food insecurity. We delivered free meals to them and their households while they were recovering at home. We also connected them to additional local food resources. And to date, we have over 2,700 food insecure members and their households been provided over 21,000 meals. And then in November of 2020, so around that time of the COVID patients, we also launched an initiative that provided discounts on healthy food at grocery stores. So we were really trying to figure out creative ways to get people food and help them expand their purchasing power to be able to eat, have food and also eat healthier food during the pandemic.
Mikkel, that's a lot to pick up on, but I'd like to add any points you want. In addition, I'd like to come back to something you talked about, which is the social screening and using predictive analytics to identify who's in need, but also more of a personal dimension. How readily do people talk about their need to get access to food? How do these conversations work? Or is it the people in the community, it is such an essential need that they readily talk about that they need help on this, or is it something that you find that providers raise and because you've identified that they potentially might be in need? How do the conversations go?
Yeah, I'll start there. I think something Pam said really resonates for us. What we have found is that our patients and members and even our caregivers appreciate being asked if they have a need. And that as soon as they're asked, there's almost this wave of appreciation that we consider this an aspect of health and that we would be so caring as to ask about aspects of their home life, food, housing, safety, etc. The harder part for us has been really convincing our caregivers that how to get comfortable with asking the question. There's that's taken some training and coaching to help people know how to ask those questions. And so, we're really careful about the tools that we use. We have a different tool for families with young children, and then a tool for adults and older children. And we focus really on how do we support our caregivers in being trained to ask those questions. A lot of it can be automated or sent out in advance, and then it becomes more of a conversation as opposed to a screen, which has really helped in terms of the process. And then the other area that has really helped us is doing some predictive analytics to understand whom do we need to have those careful conversations with most. And so we are using a vended solution through Algorex that connects data we have about our patients with other data to suggest who needs proactive outreach, because even though we're screening in clinics or in emergency departments and inpatient environments, a lot of the people that are most in need are those that are not coming. And that was especially true during the pandemic. And so outreach to people based on prediction has proved to be very effective. And I think also addressing some of the disparities that we know exist, but were uncovered actually even further during the pandemic, as some people really did not seek care for extended periods of time, and we had no opportunity to interact. So that phone call or text and connection to someone based on prediction that they had a need has proven to be very effective, and not only in resolving their food insecurity and other social issues, but actually re-engaging patients with care, because we were able to create a connection through food. It's the way we connect. We often think of food as the great connector socially, and that's been true even reconnecting people through those outreach mechanisms to healthcare again.
I have a real-time audience question follow-up to what you just said. So when you're doing the social screening, is there a database or a community resource database that your screeners can automatically say, here's where you can go, or is there like a second step that has to happen, in a different phone call after that?
So we have a platform that we use called Unite Us that our caregivers can tap into to connect a patient to social services, whether those are food services or other needs. It's supported on the back end in collaboration with our 211 infrastructure to create a closed loop referral mechanism. So when someone's referred to services, and they can be referred to multiple things at the same time, there are people working to ensure that that need gets met and prompting follow-up with the patient or member to ensure they're getting access to those resources. It's in different levels of maturity depending on the community. In some communities, we're really far along and then figuring out what are the gaps, where are the problems, and using that network to close the loop. And we're further along in problem solving. In other areas, we're still kind of developing the infrastructure behind that network. So it depends. But I think this is the future. We all do our part in managing a network of skilled nursing facilities and therapists and hospitals and clinics to help support our patients and members. This is the beginning of a social network that will be a really important part of managing health in the future.
That is such an important point. And actually, Kara, if you could pick up on that, what you've all started to say is these food insecurity, food as medicine programs, they actually encourage a much deeper, better relationship between providers and the community members. You're really addressing some of their biggest anxieties, and it's appreciative, which can have rollover benefits as you try to manage people's health over the course of their lives. Can you talk about just some of your programs like the Can Grow Garden Initiative, and just the way some of these programs have different benefits that maybe you didn't even expect when you started them?
Yeah, I think that it is such an important opportunity to engage your patients, families, and communities when you think about food insecurity and other social needs. It is one of the top 3 issues that we find on our social screener, right alongside community safety and reliable internet. And I think that is just tremendous when you think about how essential internet is, like running water these days, to getting needs met. But food is one of those issues where partners are incredibly important because it's an ongoing daily need, and we see them fluctuate over time. And so whether we're partnering with our United Way 211 system to work with food banks, or think about backpacks for food weekends or food pantries, we see these interconnections and partnerships really critical. One of the programs that we have established is our Can Grow Garden, which is actually a program on our campus that's designed to help empower Nemours families to grow food at home. And we grow food on our campus, and we have raised beds outside of our cafeteria that are basically a demonstration garden to show families how to grow tomatoes and other fruits, vegetables, and opportunities to think about having fresh produce at home for anyone who may need it. All the food grown in the garden is harvested and regularly offered to patients and families, and anything that isn't claimed by our families goes to the food bank. I think it's really incredible. We have quite incredible grounds that they grow at least 1,000 tomato plants each year in our state's greenhouse. That's part of the Nemours family legacy. But these plants, they grow in containers, and people can bring them home. And then we have learnings and lessons along the way. And so working with our child life and the support of our volunteer services and nutrition, these programs extend the learning. I remember meeting a young woman who said once, "I never knew what kale was, but after I grew it myself, I never knew kale could taste so good." And I think that's just the power of learning as you experience life, as you see it grow with your own hands and your own watering. But it also does address these needs and give families tools, whether they're in urban settings or other places where they have more access to space, green space to grow on their own.
That's terrific. One of the other notable benefits of the food security efforts are that it's also bringing together community members, community partners in unique ways. And Lisa Eskenazi, as a safety net hospital, you constantly have to be resourceful in how you maximize resources, get people to help. Can you talk a little bit about the food pantry grocery store that you set up, how it happened, your church partnership, and how everything came together?
Sure. Yeah, well, thank you. I'm just loving thinking about everything that's going on across the country. So it's very encouraging. And we've shared data. We've all we've shared some of our data, and it's pretty sobering. And it's pretty much the same message, whether you're talking across the country or just here in one county. For example, a third of our patients, presented primary care screen positive for food insecurity. But all of our data, no matter how dramatic the numbers, can become numbing, I think, because it's faceless. And so when we talk about the issue of food insecurity in our community, we start by describing the day in one of our neighborhood health centers when the waiting room was disrupted by a young boy who was chasing another child around the waiting room. And as his concerned pediatrician, Deanna Reynoso, later learned, the reason that he was chasing this child was that he was hoping the child would drop some of the Doritos out of the bag that he was carrying, because this young boy had not eaten for 2 to 3 days. So that's when you really start to think about what that feels like, that, ignites, you've got, this passion to do something. And in this case, it's what ignited what we call the Crooked Creek Food Pantry, which is now a full service client choice pantry that's located within that health center, the Eskenazi Health Picard Health Center. It's possible because of a partnership between St. Luke's United Methodist Church, Corteva, formerly Dow AgriSciences, and Eskenazi Health as founding partners, and then enabled by a partnership with Gleaners Food Bank of Indiana, which is our largest distributor of food. It's now a 501c3 nonprofit. It's led by a volunteer board of directors. We have roughly 120 volunteers contributing more than 500 hours a week. And we had a system for screening for food insecurity that predated the pantry. It wasn't as sophisticated as the process I think we all now have in place that's an integrated component of our electronic medical record that enables us to screen for an array of the social drivers of health. But I don't think its lack of sophistication was the reason it wasn't used that much. The care providers throughout our system in the course of their daily work are constantly pushing back against the societal injustice that results in health inequities. The issues are ever present, and absent effective solutions, they can become demoralizing. So it wasn't until we created something that the providers could do about it that the screening really took off. And what they could do about it was, as Kara was describing, write a food as medicine prescription for registration at our food pantry. And so, then they could just go down the hall and fill that prescription. So the individuals register to shop at this co-located pantry, and it's stocked with fresh produce, frozen foods, dairy, eggs, meats, other staples, and it's based on family size. I think it provides an important advantage, in terms of convenience, reducing stigma of having to go somewhere else for food, but also just some of the small capacity pantries that fill a need, but with the shelf stable canned and dry food products that are high in sodium and carbohydrates, that diet that often runs contrary to the needs of individuals with chronic health conditions. So we exist on the strength of our partnerships, and we have multiple faith-based organizations, local employers, large-scale food grocers, agribusiness partners, other large-scale pantries. And then in 2017, again, following Kara's arc here, we partnered with Indy Urban Acres to create an 1.5 acre farm on the grounds of the health center. And that added to the produce that was already being contributed by a garden that had been planted there and was being maintained by a local church. And also another big contributor has been the produce off of our 5,000 square foot Sky Farm on top of our Sandra Eskenazi Outpatient Care Center on our downtown hospital campus. So the produce goes there and also into our other neighborhood health centers. But then, as the demand has grown, as we've all discussed. So we relocated the initial pantry within the health center, but we repurposed a large community room so that we could add freezer capacity and general space to serve a volume of about 80 clients an hour, which is what we're seeing now. And then when the pandemic hit, we essentially turned the pantry into a warehouse and moved to a car line model, in addition to home delivery by our community health workers to individuals who were either isolating or recovering from COVID. And this allowed us to adjust to a 70% reduction in the availability of volunteers, most of whom are older adults who had their own challenges with the pandemic, while still managing the 35% increase in need for food, as both the health and the economic consequences of the pandemic landed hardest on those already bearing the disproportionate burden of poor health.
You know, one of the old saws about healthcare is that it's like moving the Titanic to get change. And what's extraordinary about this conversation is how much experimentation, willingness to do pilot projects and new projects to see what works is so critical to the success that you all are having in making a dent in your health systems. And Pam, if I can turn back to you, there's an audience question that actually ties to a question I wanted to ask you, which is back to, we're being asked is, has there been any published paper on using food as a tool to prevent readmission that they could tie into? And then also, if you want to add on to that, are there some new programs that you're testing right now that you want to talk about tied to the food as medicine programs?
Thanks, Liz. And maybe I'll switch up the order for a second, because I want to just pick up on what you said about a lot of tests going on. And we are seeing that across the nation in ways that, I've worked at Kaiser for over 20 years, and I haven't seen what I see now in terms of experimentation across healthcare, and in particular in some of these innovative solutions that we've been talking about. And I think that the pandemic gave us an opportunity to accelerate all of that, but it was already somewhat happening before food insecurity existed pre-pandemic, and then it just accelerated, which made it easier for us to try some things, or at least that's what I was seeing. And so, it's and I'll talk about the publications in a second when I lay out where we are with the studies. This panel has already talked about the importance of food as medicine, and in particular, medically tailored meals, and Kara touched on produce prescriptions. And as we were developing our approach to food insecurity, so back in pre-COVID 2018, we asked the experts that we were talking to, experts in food insecurity, what Kaiser Permanente should do to address food insecurity. And they did not miss a beat at that time in saying that we should take on medically tailored meals and produce prescriptions, but they asked us not just to implement, they asked us to help build the evidence of what works and under what conditions, because the evidence was still sparse. And I would argue that it still is sparse about how you implement it. And so, meaning like the duration of meals, number of months, how many meals a day, which disease categories, all those are still being built out. You've heard some reference to certain disease categories, but there's still some missing evidence, at least for healthcare to fully embrace what's possible here, and in terms of building the business case. So let me just say where we are with our studies. In 2020, so just as April 2020, just as COVID was entering our world, we launched 3 medically tailored meal studies for members who had been recently discharged from the hospital with nutrition impacted chronic conditions, similar to what was described by Lisa and by Kara. And we just completed the data collection. We have over 2,100 patients, almost 120,000 meals delivered to them. And we intentionally designed our studies to include variations to really help us understand what works and under what conditions. So we looked at things like I mentioned, like the number of weeks of meals, the number of meals a day. Do you include nutrition counseling? Do you feed the household so the hungry mom doesn't give her food to her hungry child and not use it for her recovery? And then perhaps most important, we're also trying to understand which disease categories lead to better health outcomes and cost savings. And from these studies, we're learning a ton about the best way to deliver medically tailored meals programs. And we're also building the evidence, and I would say the business case, and informing the broader rollout of medically tailored meals moving forward as some of the regulatory environment shifts in both Medicare and Medicaid for this to be more embraced by healthcare during this all played out during our studies. The second study that I want to mention is around produce prescriptions. And I think it was Kara who mentioned this, but there is quite a buzz in lots of food as medicine conversations about produce prescriptions lately. It's a promising innovation which can bridge the gap between healthcare and food systems. It's a practical, scalable, sustainable, and affordable intervention that uses healthy food prescriptions to improve clinical outcomes, but also can touch on quality, quality of life, and equity. And so the evidence even more sparse for produce prescriptions than it is for medically tailored meals. So just last November, around Thanksgiving, we launched a study to test randomized controlled trial to test produce prescriptions by providing healthy food boxes and nutrition education to people with diabetes who are also food insecure. And there is quite a, we're just getting started here, but there's quite a bit of excitement already from both our patients and our clinicians about the study. And to date, we've delivered over 750 food boxes to these households. And each of these initiatives that I mentioned, all the way up to back when I was talking about SNAP, they have a robust evaluation and, when possible, a randomized controlled trial to really build the evidence and understand how we might modify the work moving forward. We're also pairing this rigor with qualitative data to really understand the impact on our members and their families, and also on our employees and on our business, as well as bringing it to these food as medicine national conversations like this one. And so to the question about publications, we have quite a few publications under review right now. So none of them are yet out there because they're under review, but I would imagine if you ask me this question in 3 to 6 months, I would have a different answer just because of where we are in the process, but we're trying to get things out as fast as we can.
So in other words, stay tuned.
Stay tuned. Yes.
Stay tuned.
Ask that question again.
So Mikkel, to be able to take care of the community, your caregivers have to be taken care of. And one of the unfortunate other crises caused by the pandemic was the impact on healthcare workers. And Intermountain had to turn its own sights inward when it turned out that a lot of your employees became food insecure. Can you talk about how you identified that problem, what you did, and what was the impact on the morale inside the organization?
Well, thank you for the question. I think, as the pandemic was unfolding, there were immediate responses to support caregivers. We had lots of community partners bringing food to our care sites and, offering support. And that became a great way to support local businesses that were not able to be supported by public consumption during that time. And so that really launched us into thinking then, well, all right, we've got this immediate response that we've created for our caregivers, but what is the true need and how do we surface those needs? Intermountain, probably like lots of health systems, has always had an employee assistance support infrastructure, but it wasn't really broadly known, and it didn't work proactively to identify people in need as well as we would like. So we really began to pay attention to that during the pandemic. We asked all of our HR support teams, leaders, and others to be aware of needs among their team members, looking out for one another. And we began to actually survey our caregivers about their needs. And as a result, started delivering food boxes in partnership with a food distributor partner in our community. Our employees now can receive a 7-day food box tailored to the size of their family when they self-identify as having a need, or when we outreach to them, or when a manager or HR leader reaches to them. But more importantly, even those well, there's two things I'd like to share. First of all, we delivered the food boxes using our home health team. So other Intermountain caregivers were delivering food to their peers, and that created wonderful compassion and was really uplifting to everyone on both sides of receiving and giving. But the other thing we've done is really try to understand what's prompted that need. Intermountain has focused on paying a livable wage, supporting the benefits of our caregivers in a way that respond to everyone having opportunity for economic growth in their own families. And we really wanted to understand what's prompted the need for food. amongst our own caregivers. And so now anyone who's receiving that food support is also going through a comprehensive support planning process with a financial counselor and doing some financial planning. In lots of cases, it's related to another person in the family or some other type of disruption. But in some cases, there really is a need for developing a more comprehensive plan. And we've been able to support our caregivers in doing that.
Kara, one of the other challenges raised by the pandemic is mental health and behavioral health, particularly among kids. And have you seen an uptick in eating disorders that have arisen because of the stress of the pandemic? And how are you at Nemours trying to address that?
I have not seen a health system yet say they haven't seen some impact of COVID on mental health outcomes across our nation. And we have seen COVID dramatically impact our families and our children's, probably connected to disruptions in school, impacted social supports, and ongoing widening health inequities that are connected to mental health access. And so we've seen this mental health crisis truly escalate among children and youth, even more so among adolescents. I would say whether it's anxiety or depression or other rates of suicidality, they have impacted us. We've seen an 80% increase in the last year in patients in our ED with chief concerns of suicidality or intentional harm. And unfortunately, that connects to eating disorders as a manifestation sometimes of anxiety, depression, or other undiagnosed mental health conditions. And so the impacts have created this disruption in how we connect and how we care. But I would say that because of this connection, there's this interesting divide between eating disorders and then also the increased rates of obesity and overweight that we've seen with COVID. So we have a lot more to do. And I think the ways that we're trying to address that are addressing the whole child, addressing the mental health needs alongside the physical health needs. And whether we're doing that in our primary care settings and screening work, or whether we're doing that in our emergency departments, we have seen the need explode, unfortunately, during COVID and in this current time. And I think that's where we're trying to figure out, again, how to increase access through our clinical care, through expanding the needs, through figuring out a continuum that focuses not only in primary care settings, but beyond, and then also leveraging expanded telehealth access. I mean, everyone's doing it, but we have seen the need and opportunity to leverage telehealth into behavioral health and mental health is critically important. But for those with eating disorders, I think sometimes you just need a stabilization pathway. We need embedded clinical care in our practices in our continuum, and really have an ongoing challenge ahead of us, I think, to make sure that we're taking care of all of the mental health we've seen in the past 2 years.
Thank you. And Lisa, if you want to pick up on those comments, please do. I also want to pause because we're getting some questions about funding, because the people in the audience feel these programs are very important. We've talked about some of the federal sources, but also as a safety net hospital, you have to be very creative and diverse in where your funding streams are. Would you mind talking a little bit about that and sharing how you do it, how you get your funding?
Sure. And I would say first, under the heading of stay tuned, we also have a publication under review that is with the International Journal of Integrative Care. And this one really talks about the inception of these programs and how we built them and how they evolved and how we're maintaining them. And so there's a lot of discussion about funding. So for folks who want more information, I'll just hit on some highlights. It obviously takes funding on a large scale basis for a large scale food pantry takes a commitment from the health system and a host of community partners. And just to put things into perspective, our annual budget for the clinic-based food pantry has grown from $60,000 in 2015 to $360,000 currently. And this doesn't include the value of the donated food, which is estimated at about $2.5 million annually. And our paper will describe the breakdown of where those contributions come from. But it's basically federal, local grants, corporations, again, faith-based organizations and individual donors. But when the COVID-19 pandemic caused a large surge of the food insecure individuals, we began to participate in the U.S. Emergency Food Assistance Program, or TFAP. And this is a federal program for low-income Americans that provides emergency food assistance at no cost. And the USDA actually provides food and administrative funding to states to operate TFAP. So that's a partnership. And that affiliation provided us between $20,000 to $30,000 additional retail value of food monthly that allowed us to distribute increased volumes at lower food procurement costs. Unfortunately, though, we don't know how long this benefit will continue. And one of the potential sustainability challenges is just going to be adjusting to a decrease in that support. We also participate in 2020 in the USDA Coronavirus Food Assistance Program. And this was implemented initially to provide assistance to farmers and ranchers and producers who were impacted by the market disruptions, but it provided us additional food for distribution. This program for now has been discontinued, but it's the kind of thing that could come back as the need waxes and wanes. And I actually was taking notes. I think I'm glad that Pam talked about SNAP, and we worked really hard to get everybody on SNAP. We haven't done texting yet, so I'm going to be reaching out. I think the value of this is we get to borrow from each other's playbooks. So I think we have to see that SNAP is just the safety net under all these programs. And I think all of us should be doing as much as we can. But you also, since you asked, and what more we'd like to see, I just wanted to add that the hard truth is that we all struggle to fund these programs, and the long-term sustainability is going to depend on payers or society's willingness to pay for these services. We readily pay for the ED visit or the hospitalization. 20% of our gross domestic product going to sick care. And we've talked about how little we contribute, but it's about 10%. The entire biomedical model applied to treating disease, it accounts for about 10% of reduced mortality. That's not very much. That's how big this gap is. So we pay for that sick care, but not for the public health social services that for pennies on the dollar could prevent the untoward events, the trips to the hospital. And I think, we've touched on it, but we really, everything we're doing is nibbling around the edges. We need to address the root causes of poverty. And, we talked about the misperception of, how people can be obese and food insecure and malnourished at the same time. That's all about the food deserts and, access to low cost, high calorie, nutritionally devoid food, and how counterproductive that is to the needs of individuals with chronic illness. But another dangerous misperception about the folks that we're all caring for here is that they don't work. When in fact, the majority of families relying on food assistance are working families cobbling together multiple jobs, none of which offer health insurance or wages high enough to relieve them of the burden of having to choose, for example, between medications and food. And the problem of poverty is the problem of the huge gap we have in our country in terms of opportunity and wealth, and we need to close that gap. And I think a good start's a living wage. So I'll just end there.
No, thank you. We just have 2 or 3 minutes left. And one group that we haven't talked about is new mothers and newborns. And Mikkel, I wonder if you could just take a moment to talk about how imperative it is to make sure that breastfeeding mothers with their newborns are not food insecure, and what has Intermountain done in this area?
Well, we do the same screening that I've described for pregnant women, and offer some additional support because we know that first, that prenatal care and the first 2 years of life are so impactful on long-term health outcomes. We have a pilot actually underway in the spirit of contributing to the evidence of identifying those first-time moms that are at highest risk, have the largest social needs, and connecting them with a home visitation program through nurse-family partnerships. This program used to be funded through federal grants, and the grants have, are no longer supported. We're putting the program basically in place in a way here that allows for us to demonstrate the impact on reducing spend in medical expenses, but also some non-medical spend by providing it in partnership in our community, actually building on the Alliance demonstration community that I mentioned previously in Weber County. So a new mom will get enrolled prior to 28 weeks and receive home visitation through the first 2 years of their child's life, connecting them to nutrition programs, but also parenting support and other social support. And we'll be publishing around the results of that study as well. Thank you, Liz.
I think, Kara, if I can ask you to close, what Lisa just said is part of the point of this discussion is to help share best practices. And if you could talk just to end the discussion about the Healthy, Hunger-Free Kids Act and what Nemours did, and maybe how it sets a template for how we can move forward in the future to get these programs out nationwide.
I think that's an example of where health systems can't do this alone and take on food insecurity, but we have to have stakeholders and every level of government involved. In 2010, Nemours Children's Health joined partner organizations through a coalition to support the passage of a child nutrition reauthorization bill called the Healthy, Hunger-Free Kids Act. It's an example where advocacy mattered. We advocated for strong nutrition standards in the child and adult care food program, the National School Lunch Program, and then worked to strengthen local school wellness policies. At that time, we joined First Lady Michelle Obama to launch the Let's Move program. And more than a decade later, we're continuing to embrace those opportunities to work with early care and education, healthy food options in childcare environments. But actually, the child nutrition reauthorization is up for reconsideration. And so we need stakeholders and others who may be listening to let me know if you're willing to partner, because I think this is one more opportunity to address food insecurity and strengthen federal nutrition assistance programs. So thanks for everyone to identify this as a critical priority. It certainly is one for Nemours. And we think it really is most impactful when all stakeholders in the community come together, including government, to advance these programs and policies.
Wow, I want to thank you all for such a rich, substantive discussion. It has truly been a privilege to share a conversation with the leaders on this panel who are working so creatively and indefatigably to alleviate one of the nation's most serious public health challenges. Thank you all.
Thank you.
Thank you.